Pediatric urinary tract infection, etiology. Urinary tract infections, UTIs, include cystitis, infection, localized to the bladder, pyelonephritis, infection of the renal parenchyma, colitis and renal pelvis, and renal abscess, which may be intrarenal or perinephric. The urinary tract and urine are normally sterile. Escherichia coli, ascending from bowel, perineum, flora, accounts for 85% of first infections. Other bacteria commonly causing infection include Klebsiella proteus, Enterococcus, Pseudomonas, and Enterobacter. Staphylococcus saprophyticus is associated with UTI in some children and accounts for 15% or more of UTIs in adolescent girls. Staphylococcus aureus is an uncommon cause of UTI and usually represents bacteremic seeding of the urinary tract. Clinical manifestations. The symptoms and signs of UTI vary markedly with age. Few have high positive predictive value in neonates with failure to thrive, feeding problems, and fever as the most consistent. Symptoms. Infants 1 month to 2 years of age may present with feeding problems, failure to thrive, diarrhea, vomiting, or unexplained fever. The symptoms may masquerade as gastrointestinal illness with colic, irritability, and crying periods. At 2 years of age, children begin to show the classic signs of UTI, such as urgency, dysuria, frequency, and abdominal or back pain. The presence of UTI should be suspected in all infants and young children with unexplained fever and in patients of all ages with fever and congenital anomalies of the urinary tract. Elaboratory end-imaging studies, the diagnosis of UTI in infants and young children requires the presence of both puria and at least 50,000 CFU/milliliters of a single pathogenic organism. For older children and adolescents, more than 100,000 CFU/milliliters indicates infection. It is appropriate to obtain urine cultures by midstream clean catch technique for older children and adolescents, whereas transurethral catheterization or suprapubic bladder aspiration is the appropriate method for younger children and infants. Perineal bags for urine collection are prone to contamination and are not recommended for urine collection for culture if there is uncertainty about diagnosis of UTI in a younger child or infant. Urine can be collected by the most convenient method for urinalysis, and if suggestive of infection, collect urine by catheterization prior to starting antibiotics. Urinalysis showing puria, leukocyturia of 10 white blood cells/M, M3, suggests infection, but is also consistent with urethritis, vaginitis, nephrolithiasis, glomerulonephritis, and interstitial nephritis. Other urinalysis findings suggestive of infection include any bacteria per high-powered field in the unstained, uncentrifuged urinary sediment. Positive urinary leukocyte esterase test and positive urinary nitrite test. Combined testing for leukocyte esterase, nitrite, and microscopic bacteria has almost 100% sensitivity for detecting UTI by positivity of one or more of the 3 tests. The negative predictive value of a urinalysis is about 100% if all 3 tests are negative and may obviate the need for culture, except in neonates, where urinalysis results are less reliable predictors of infection. Ultrasonography of the bladder and kidneys is recommended for infants and non-toilet trained children with first-time febrile UTIs to exclude structural abnormalities or detect hydronephrosis. Voiding cystoarthrogram VCU is indicated if the ultrasound is abnormal, hydronephrosis, scarring, or other findings suggesting obstruction or congenital abnormality. Vesicoureteral reflux is the most common abnormality found and is ranked from grade I, ureter only, to grade V, complete gross dilation of the ureter and obliteration of calyceal and pelvic anatomy. See chapter 167, Atecnate-iron 99M. Dimacaptosacchinic acid, DMSA. Scan can identify acute pyelonephritis and is most useful to define renal scarring. As a late effect of UTI, differential diagnosis. The diagnosis of a UTI is confirmed by a positive urine culture, but this does not distinguish between upper and lower tract infection. Localization of a UTI is important because pyelonephritis is associated more frequently with bacteremia and anatomic abnormalities than is uncomplicated cystitis. The clinical manifestations of UTI do not reliably distinguish the site of infection in neonates, infants, and toddlers. Fever and abdominal pain may occur with either lower or upper. UTI, although high fever, vomiting, costovertebral tenderness, leukocytosis on complete blood count, CBC, and bacteremia each suggest upper tract involvement. Treatment. Therapy should be initiated for symptomatic children and for all children with a urine culture confirming UTI. For infants and children who do not appear ill but have a positive urine culture, oral antibiotic therapy should be initiated. For all young infants and any child with suspected UTI who appears toxic, appears dehydrated, or is unable to retain oral fluids, initial antibiotic therapy should be administered parenterally. Neonates with UTI are treated initially with parenteral antibiotics because UTIs in this age group are assumed to occur from hematogenous spread regardless of blood culture results. Often, if there is rapid clinical improvement and initial blood cultures are negative, patients can eventually be transitioned to enteral antibiotics to complete a 14-day total course of therapy. Older children with febrile UTI are treated for 14 days of enteral antibiotics or a combination of parenteral followed by enteral antibiotic therapy. Initial treatment with parenteral antibiotics in this age group is determined by clinical status. Parenteral antibiotics should be continued until there is clinical improvement, typically 48 hours, defined as resolution of fever, and improved oral intake. Empirical antibiotic therapy should be guided by the local antimicrobial susceptibility patterns and the results of the patient's prior urine cultures. Because of increasing problems related to antimicrobial resistance, definitive antibiotic therapy should be guided by the patient's urine culture results. Commonly used empirical parenteral antibiotics include cefazolin, ceftriaxone, or ampicillin, plus gentamicin. Oral regimens include cephalexin, amoxicillin plus clavulanic acid, trimethoprim sulfamethoxazole, or fluoroquinolones, older children only. Infants and children who do not show the expected clinical response within 2-3 days of starting antimicrobial, their AP should be re-evaluated, have another urine specimen obtained for culture, and undergo imaging promptly to evaluate for renal abscess. Prevention. Primary prevention is achieved by promoting good perineal hygiene and managing underlying risk factors for UTI, such as chronic constipation, encopresis, and daytime and nighttime urinary incontinence. There is evidence that antibiotic Prophylaxis may prevent more severe symptomatic recurrent infections, although the effect is small and is associated with the development of resistant organisms. The impact of secondary prophylaxis to prevent renal scarring is unknown. Acidification of the urine with cranberry juice is not recommended as the sole means of preventing UTI in children at high risk.